بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is the second part of the talk about the pulmonary vascular lesions, and in the first part we have finished the issue of the pulmonary embolism as well as the chronic thromboembolic pulmonary hypertension, and also we finished the issue of pulmonary arterial hypertension, and now we are going to discuss the remaining issues, and we'll start by the pulmonary vasculitis. And vasculitis means inflammation of the vessel wall, and we have two types of this inflammation: lesions that affect the large vessels, and the example for this is the Takayasu arthritis and Bassett disease. Also lesions which affect the small vessels, which are intimately related to this anti-neutrophil cytoplasmic autoantibody vasculitis, and the examples are Wagner granulomatosis and Sherbet-Strauss syndrome. Vasculitis will lead to inflammation of the vessel wall, and this may lead to vessel wall thickening, nodular or cavitary lesions in the lung, ground glass opacities, and consolidations. Actually, when the vessel wall is inflamed, it may become thickened and encroach on the vessel lumen, which may result in obliteration of the vessel lumen and thrombosis. Another issue is the inflammation will cause weakness of the wall of the vessel, and this will lead to some expansion and aneurysmal dilatation. One of the important issues here is that in this category you need the help of the clinical data, radiological findings, laboratory findings, and even histopathologic features in order to reach the final diagnosis of the disease. Takayasu arthritis is one of the large vessel vasculitis, and this is the normal appearance of the artery and the lining of the artery. And in Takayasu arthritis, there is the granulomatous inflammation of the vessel wall, leading to marked intimal proliferation and fibrosis, and this will lead to considerable narrowing and stenosis of the vessel, and also you may get post-stenotic dilatation in some of the situations. Then Takayasu arthritis is one of the idiopathic vascular disorders. It involves the major vessels, especially the aorta and the pulmonary arteries, usually affecting young women, as I have mentioned, leading to granulomatous inflammation of the vessel wall, intimal proliferation, fibrosis of the media and adventitia, leading to considerable narrowing of the vessel lumen. And this is the main pulmonary artery segment, and you look how there is marked narrowing of the right and left main pulmonary arteries with marked thickening of the wall. And if you give contrast intravenous contrast material and you got enhancement of the thickened wall, this may indicate that the disease in its active stage. And this is the non-contrast CT scan of the mediastinum, showing some calcium in the wall of the aorta and the wall of the pulmonary artery. The main trunk is good, and the left branch is also looks of normal caliber, but the right main pulmonary artery is markedly reduced in caliber, as you can see here. And this is one of the ways to treat this type of arthritis, is to place a stent in the narrowed segment in order to maintain the patency of the vessel lumen. And this disease needs also the help of steroid and immunosuppressive therapy, and you can see the stent as I have mentioned. And we came to the Behçet disease, which is also vasculitis affecting the major vessels. And Behçet is a chronic multi-system vasculitis, affects the second and third decades of life. Males are equal to females, and the cause is, of course, unknown. The clinical manifestations of Behçet disease include mucocutaneous ulcerations, arthralgia, iritis, uveitis, optic nerve atrophy, and maybe blindness. The major radiological manifestations of Behçet disease include arterial aneurysms, especially of the pulmonary arteries, and venous thrombosis, especially of the major vessels, including the vena cava. And here you see this is the arch of the aorta. There should be here the superior vena cava, which is not present, meaning that it is occluded, and you can see the multiple collateral venous channels in the mediastinum. And thoracic involvement in Behçet disease is in the range of 1 to 8%, and it affects the large and medium caliber vessels as well as some of the small vessels. Behçet commonly affects the pulmonary arteries second to the aorta, and the major manifestation here is the formation of pulmonary aneurysms, which are usually multiple and maybe bilateral, as you can see here. This is the normal appearance of the pulmonary artery on both sides, and compared to this, the artery is considerably dilated, and you got some mural non-enhancing thrombus on both sides, and this is the patent lumen. Then the most common cause of pulmonary artery aneurysm is the Behçet disease. The manifestation is usually by hemoptysis. Aneurysms are fusiform or saccular. Commonly they are multiple and bilateral. Aneurysms are located usually in the lower lobe along the main pulmonary arteries. Frequently, aneurysms are partially or totally thrombosed. Here is see the mural thrombus in the patent lumen, and the mural thrombus. One of the important issues is that untreated aneurysms have a high risk of mortality, which may reach up to 30% within 2 years. The resolution of the aneurysms with immunosuppressant drugs is seen in about 75% of the cases. And this is a case of Behçet disease, showing bilateral large pulmonary aneurysms. The left one, there are 2 on the left side and 1 on the right side. This aneurysm is partially thrombosed with a large thickness mural thrombus, and here is another aneurysm with small mural thrombosis. And you may have the help of multi-detector CT to form 3D images, and also you can have it in color. Then you can appreciate the distribution and the number of the aneurysms in any case. And here is another patient with Behçet disease presenting by hemoptysis. And you can see that there is a big aneurysm on the left side with a small mural thrombus compared to the normal caliber of the artery. And here is the same case I have presented just in a moment. You see the superior vena cava is thrombosed with collateral vessels in the mediastinum, and also the patient had bilateral pulmonary aneurysms with mural thrombosis on the right and on the left as well. Then the causes of pulmonary aneurysms include either congenital or a manifestation of vasculitis, especially in Behçet syndrome, or infections as in pulmonary aspergillosis, TB, and syphilis, and this is known as mycotic aneurysms. But of course, the most common cause of pulmonary artery aneurysm is the Behçet syndrome. This is MRI, coronal and axial images showing a huge pulmonary artery aneurysm affecting the main pulmonary trunk and part of the left branch as well, and the aneurysm is totally patent. There is no mural thrombosis. Then we came to the small vessel vasculitis, starting by Wagner granulomatosis, and you remember that it is related to an anti-neutrophil cytoplasmic autoantibody, and this is the the most common type of this category. It affects predominantly the lung and the kidneys in about 90 and 80% of the cases. Wagner granulomatosis is a triad affecting the upper respiratory airway, the lower respiratory airway, and the kidneys. The pulmonary symptoms include hemoptysis, cough, chest pain, and dyspnea. Upper airway involvement may lead to rhinorrhea, epistaxis, sinusitis, or otitis media. Then Wagner granulomatosis have these stages of affection of the vessel wall. The first is vasculitis with inflammation of the vessel wall located within inflammatory pulmonary inflammatory nodules. Then necrosis will happen in the vessel wall, leading to granulomatous inflammation, and this is associated with neutrophilic infiltration and microabscesses, which will present later on as the pulmonary opacities, which we'll see in the chest radiograph and CT as well. Wagner granulomatosis is a triad of upper airway disease, lower airway disease, and glomerulonephritis. The subglottic tracheal stenosis is one of the manifestations of Wagner granulomatosis. Then, inflammation of the vessel wall may lead to granulomas, and the granulomas are the sequelae of confluent necrotizing lesions, as I have mentioned, and this will result in, at first, pulmonary nodules that are scattered throughout both lung fields, and these lesions are numerous, bilateral, subpleural in 90% of the cases, and after that the lesions will coalesce and enlarge in size and later on cavitate. Then we start by nodules, then masses, and cavities. At the stage of nodules, the differential diagnosis of this appearance include, as you remember, metastatic disease, miliary TB, sarcoid, and rheumatoid lung. And if the nodules coalesce together, they form larger nodules, then they form masses, and the differential diagnosis will be also the same. And nodules larger than 2 centimeters are usually will develop cavities in the nodule, and some of the nodules are surrounded by ground glass opacity, which is known as the CT halo sign, seen in 15% of the cases. Then this is the usual or the familiar appearance of Wagner granulomatosis, is the presence of multiple cavitating pulmonary nodules. And if you remember, I have mentioned previously in this part of the first part of this lecture, the differential diagnosis of cavitating pulmonary nodules, and I include the vasculitis, especially the Wagner granulomatosis. Then Wagner will start by miliary nodules that they will coalesce together to form larger nodules. Then nodules more than 2 centimeters will cavitate, forming multiple cavitary lesions. Also, Wagner granulomatosis may present by areas of consolidation, and these areas of consolidation may show internal air bronchogram. The cause is either infection or hemorrhage. Both can present by a consolidative area like this, and both are common in patients with Wagner granulomatosis. But if you are asked to diagnose a lesion like this, and they want to select, if you want to select one of these two conditions, I think that it's better to diagnose this as hemorrhage rather than pneumonitis, because you know that this is a type of vasculitis which is commonly cause hemorrhage in the lung. And what is the differential diagnosis of a lesion like this? Number one, a pneumonic consolidation. Number two, let us say an alveolar cell carcinoma, which is a mass with internal air bronchogram, organizing pneumonia, and even a primary lung cancer, a bronchogenic carcinoma. Then alveolar hemorrhage occurs in 10% of patients with Wagner granulomatosis. And I have mentioned previously in the lecture of diffuse lung disease, whenever you see diffuse ground glass opacities or even patchy areas of consolidation, mainly in the central part of the lung, sparing the peripheral areas with the air bronchogram is not evident in this particular situation, and patient with may have hemoptysis and he is known to have Wagner granulomatosis, then you consider the possibility of pulmonary hemorrhage. And hemorrhage may simulate any other form of consolidation like pneumonias and alveolar cell carcinoma and so on, but by the presence of the clinical data that the patient had Wagner granulomatosis, then you may suspect the possibility of hemorrhage. And this is an area of consolidation with typical appearance of air bronchogram in the right lower lung lobe in a patient with Wagner granulomatosis. Then if there is no clinical or laboratory finding to suggest the possibility of infection, then you should consider this as hemorrhage. But you remember, in patients with Wagner granulomatosis, areas of consolidation in the lung may carry the possibility of pneumonia and also the possibility of hemorrhage. Then Wagner granulomatosis may affect the tracheobronchial tree, leading bronchial wall thickening in up to 70% of the patients, and this thickening may lead to obstruction and atelectasis, and later on the patient may develop bronchiectasis. Then the treatment response of Wagner granulomatosis, 50% will resolve in response to the treatment, 40% will show partial regression of the disease with residual damage of the lung, and 10% of the patient will remain not responding to the treatment. And this is a case of Wagner granulomatosis with follow-up after 1 year, showing regression of the cavities and the nodules with residual pulmonary fibrosis and traction bronchiectatic changes. Then we came to the Churg-Strauss syndrome, which is one of the small vessel vasculitis, and here you can see multiple patchy areas of simulating pneumonia scattered in both lung fields. You need to diagnose Churg-Strauss disease that the patient had bronchial asthma, which is started in the adult age, and you should know that he has hypereosinophilia, and the pulmonary opacities are characteristically transient, meaning that these opacities are fleeting. They appear here in the chest radiograph. In the follow-up radiograph, they are located here with total resolution of this lesion and so on. Then, according to the literature, you need to have 4 or more of the following 6 criteria in order to diagnose Churg-Strauss syndrome. Number 1, adult onset asthma, more than 10% eosinophilia in the differential white blood cell count, skin rash and the peripheral neuropathy due to systemic vasculitis, as you can see here, migratory or transient pulmonary areas of consolidation, paranasal sinus abnormalities, and extravascular eosinophils in the biopsy specimen. Then if you look here and you see an irregular shaped lesion in the left lung, and this lesion carries a big list of differential diagnoses, including tumors, including pneumonias, and so on. But you need the help, as I have mentioned early in this talk, the help of the clinical data, laboratory findings, in order to reach this specific diagnosis. Then, relatively late onset of asthma, at the mean age 32 years old. The heart is considered one of the primary target organs in Churg-Strauss disease, and this is the cause of morbidity and mortality, because this disease will affect the coronary arteries and the myocardium, resulting in their damage. Being a disease or a form of vasculitis, then it may bleed. And if you look here and you see patchy areas scattered throughout in the lung, if you know that this patient had the Churg-Strauss syndrome, then you think of one of two, exactly like Wagner granulomatous. Either this is infection or hemorrhage. Then, in absence of the clinical data to support the infection issue, then you should consider these as pulmonary areas of hemorrhage. Other findings in Churg-Strauss disease, this is the common finding, which is transient areas of consolidation seen in up to 90% of the cases, interstitial septal line thickening seen in about 50% of the cases, unilateral or bilateral pleural effusion, and the effusion may be caused by affection of the heart due to cardiomyopathy. And this is a female patient, 38 years old, with Churg-Strauss syndrome. She had a history of persistent eosinophilia and sinusitis. The chest radiograph shows opacities in both lung fields. These opacities may represent pneumonic consolidations or may represent pulmonary hemorrhages. Then we finished with vasculitis, the large vessel and the small vessel. Then we are dealing with pulmonary arteriovenous malformation. The arteriovenous malformation have been discussed in the diagnosis or differential diagnosis of pulmonary nodules. And I have mentioned, if you see a nodule, meaning that a well-defined lesion that is less than 3 centimeters in diameter, and this nodule is connected to the hilum by a vascular pedicle, which represents the feeding artery and the draining vein, or a single vessel coming from the hilum to the lesion, then you think of pulmonary arteriovenous malformation. We have a simple type, which is seen in about 80% of the cases, the complex type seen in the remaining 20% of the cases. The AVM is distributed more commonly in the lower lobe, and they may be bilateral in about 14% of the cases. The arteriovenous malformation is in the range of few centimeters. It is commonly a nodule rather than a mass. No calcification, may have lobulated or smooth outline, the cord-like bands, or the vascular pedicle connecting the nodule to the hilum. Before the era of multi-detector CT, we used to use the selective pulmonary angiography to confirm the diagnosis of pulmonary arteriovenous malformation whenever you see a nodule that is connected to the hilum by two vascular pedicles, by the vascular pedicle, which represents the feeding artery and the draining vein. Then you inject the contrast material through a catheter placed at the pulmonary artery. Then you can see the feeding artery, the AVM, and the draining vein. But after the introduction of multi-detector CT, you are easily now can image the pulmonary arteriovenous malformation by simple injection of intravenous contrast material. Then you scan the lung at the phase of the contrast material is in the pulmonary artery, and you have reformatted images in the 2D and 3D planes. Then you can easily appreciate the arteriovenous malformation, the feeding artery, and the draining vein. I have also mentioned, if you have a problem with contrast injection in the CT scan, you may use as an alternative the pulmonary MRI angiography, which is not commonly do not use contrast material, but if you inject contrast material, you get improvement of the image quality. And here you can see the arteriovenous malformation with the feeding artery and the draining vein. Then pulmonary arteriovenous malformation may be multiple, and in this case you should think that you are dealing with this particular syndrome, Rindeau-Weber-Osler-Weber disease, or is known as hereditary hemorrhagic telangiectasia. Then if you see a lesion like this and you are not sure that this is an arteriovenous malformation or not, then you should have the CT scan with contrast injection in order to see the enhancement of the nodule and the vascular pedicle connecting the lesion to the hilum. And you may also have the 3D reformatted images, and you can see better the pulmonary arteriovenous malformation, the feeding artery, and the draining vein. I have said that if you are dealing with multiple pulmonary arteriovenous malformation, then you should think of this syndrome, Osler-Weber-Rindeau syndrome, which is an autosomal dominant multi-organ vascular dysplasia associated with telangiectasia of the small vessels, leading to a small, maybe cutaneous arteriovenous malformations. The incidence is about 1.5 per 100,000 cases, and the classic triad of presentation is epistaxis, multiple cutaneous telangiectasia, and positive family history. Then this is a case of hereditary hemorrhagic telangiectasia, which commonly affects the skin, the mucous membranes, blood vessels of the liver, lung, and the CNS. And you see here at least 3 vascular malformations. One is the classic vascular malformation nodule with the vascular pedicle connecting the nodule to the hilum, and this is another one, and the third one, and the fourth one representing multiple pulmonary arteriovenous malformations in a patient with hereditary hemorrhagic telangiectasia. Then we came to the neoplasms of the pulmonary artery, and these neoplasms are either primary, as leiomyosarcoma, the primary of the pulmonary artery, or secondary, meaning that invasion of the pulmonary artery by adjacent neoplasms. And the most common neoplasm that can invade the pulmonary artery is the bronchogenic carcinoma. As you can see here in this case, the patient with left-sided bronchogenic carcinoma invading the mediastinum, encasing the left main pulmonary artery, which is markedly reduced in caliber compared to the right pulmonary artery. And you know, of course, that mediastinal invasion, encasing of the mediastinal vessels, contraindicates surgery. And this is another example of a bronchogenic carcinoma central type invading the mediastinum, encasing the right main pulmonary artery, reaching the carina. Diagnostic of invasion of the pulmonary artery by a bronchogenic carcinoma. Then bronchogenic carcinoma may lead to weakness of the wall of the pulmonary artery, which will result in one of the dangerous lesions, which is known as pulmonary artery pseudoaneurysm. And you see here, this is the main trunk and this is the left branch, and you got a pseudoaneurysm secondary to invasion of the pulmonary artery wall by this infiltrative bronchogenic carcinoma extending into the mediastinum. Then you came to the primary malignancy of the pulmonary artery, which is the leiomyosarcoma, and this lesion appears almost similar to the a massive case of pulmonary embolism, for example, but there are multiple big differences in between both. The leiomyosarcoma of the pulmonary artery is rare. The incidence is 3 cases per million. It affects women in particular, twice as common as men, and the age incidence is in the range of 50 years of age, and sometimes it is misdiagnosed as chronic pulmonary embolism. But here you see a large soft tissue mass infiltrating most of the right pulmonary artery as well as its central branches, and you got also a similar lesion on the left side. Then the differences between pulmonary artery leiomyosarcoma and the pulmonary embolism are: number one, embolism. The embolus will not enhance if you inject contrast material, while the tumor will enhance if you inject contrast material. Number two, if you use the PET-CT, then the thrombus will not show any metabolic activity, while if this is leiomyosarcoma, it will show tracer uptake and significant metabolic activity. Patients with leiomyosarcoma of the pulmonary artery may present by dyspnea, chest or back pain, hemoptysis, and signs of right-sided heart failure. Then the fever, night sweats, fatigue, weight loss should raise the suspicion of malignancy. And if you look here, and this is not a usual appearance for pulmonary embolism. You got massive soft tissue mass involving the pulmonary artery and extending along its branches, forming bulky tumor, which in this case should suspect the possibility of leiomyosarcoma, and you may have PET scan, you may have biopsy, CT guided or endoscopic guided biopsy to confirm the diagnosis. هذا وبالله التوفيق والحمد لله.